So good morning everyone. Dominica Zentner is my name. I'm one of the cardiologists from the Royal Melbourne, and it's my pleasure to have a chat to you this morning about the woman with a Fontan circulation and pregnancy. So I do want to start by, obviously I know that everyone knows this is not how babies come into the world, but really take the opportunity to recognise that for a lot of us, whether or not we have heart disease, our reproductive histories are something that we hold very close to our hearts. And it is something that is difficult for many women, for many couples. And so I will be really honest. I really apologise in advance if I upset you with anything I say. That's not the aim of why I'm here. I am almost impossible to offend, so if I do upset you and you want to leave the room, please do so. That is absolutely no problem. So there's a lot of information about interactions between pregnancy and the heart, and I am talking here initially very generally, but I have put a tick next to relationships that we know also hold for women with a Fontan circulation. So even for people who have a normal heart, it is more common in pregnancy for those women to have issues with their heart rhythm, so arrhythmias. There's a very small possibility of ending up with heart failure as a consequence of pregnancy, and there has been some evidence in some congenital heart disease cohorts that maybe the outcomes long term are not so good for women who have had a pregnancy. There's also association between congenital heart disease and increased bleeding around the time of delivery, and an association that was particularly strong for women with a Fontan circulation. What we do know about women with a Fontan circulation is that there are now a number of knowns, if you like, in terms of pregnancy, and I will go into some more detail later in the talk and give you some percentage numbers as well. So there's an increased miscarriage rate, there's an increased risk of delivering small babies, increased risk of delivering babies early, and we also always need to think about, for example, the potential side effects for babies if mum's on any medication, and the question about whether congenital heart disease might come up again in the outcome of that pregnancy and the baby. Oh, I've turned it off. Right, so what I roughly want to talk about is firstly how we would approach if you or your partner have a Fontan circulation and you want to have a baby, what's known about pregnancy in a mum with a Fontan circulation, and what's not yet known, but some of the projects that are coming up which I want to share with you. So the first one, it's really important for me to make the point that I can't give personal advice for every woman with a Fontan circulation sitting in the audience, or for the parents of small girls who maybe are not here today. So this is a really general conversation. And what's really important is that it be a conversation that you have with the cardiologist that's looking after you. And I hope that the first time it comes up isn't when you turn up and say, I want to have a baby. I hope the first time that conversation's come up is actually earlier in your life when there's been a conversation about contraception and safe sex. So I really think it's a conversation that we all need to think about having with our patients early on. And then once you've had that conversation, that's behind you, and you might be thinking about having a child down the track. The question really is whether pregnancy might be possible. Is there anything that might need to be dealt with in terms of your health beforehand? And I think part of the assessment is not just to see a cardiologist, but also to see an obstetrician, ideally someone who has experience in high-risk pregnancies, and that there be a plan about how you might be looked after in your pregnancy. So what sort of conversation, what will that conversation look like? What might that consultation look like? So as a group, women who have a Fontan circulation are classified by the World Health Organization risk for pregnancy as being risk class 3, in some cases to 4. So that means that there's classified as a group of having a significantly increased risk of maternal mortality or morbidity. So we would always say that these are moderate to high risk pregnancies, and in a proportion of women, the advice might be not to have a pregnancy. In terms of assessment, it would look really very similar to the sort of assessment that most people with a Fontan circulation will have been through before. So it's going to be a conversation about how you are, your functional capacity. We're really, and I know I'm at the start of the section where you'll hear about exercise, but we're really keen to know how much you can do, because having a pregnancy is a bit like running a long-term, marathon race for the next 9 months. And if I know you do well on an exercise test, I'm going to be more confident that you'll do well carrying a baby. We'll have a conversation about what medications you're on, whether things might need to change, examination, ECG, your oxygen sats. There is some data that shows if your oxygen's very low, so less than 85%, across congenital heart disease, the chance of having a baby successfully from a pregnancy is very, very small. It's about 12%. There's only a tiny cohort that's been published, women with a Fontan circulation, where the oxygen saturations have been included, and I can tell you that was only 8 women, but in those 8 women who had a saturation below 85%, none of them ended up having a baby at the end of pregnancy. So there is some data that can inform our conversation. We want to have an echocardiogram to know how your ventricle is working particularly, and as I mentioned at the start, the exercise test in terms of how well you are physically, because that will give us more confidence. That's really what we call the preconception counselling process, and it's a two-way conversation. It's us hearing what you want, us talking about what might need to change. I've got patients who make commitment, for example, to losing weight, getting fitter and coming back in 6 months' time to have the conversation again, and that certainly has led to successful pregnancies in some of my patients. But really the hope that is at the end of that conversation you have an idea about the health challenges that pregnancy might bring for you, and I think it's also important that that be extended to consider what the health challenges might be for the baby and the challenges that might be there for your partner. So in really general terms, what do we know in terms of pregnancy in the Fontan circulation, and what are the challenges in general? So women with chronic disease tend to have less regular menstrual cycles. They tend to have lower ovulation rates, and that certainly carries through into women with a Fontan circulation. So the chance of getting pregnant is lower. The chance of staying pregnant is lower. We know that women with a Fontan circulation have higher miscarriage rates. You need to commit at the start, but I don't think this is an issue for women who want to have a baby, but there is obviously that commitment to the fact that you'll be coming in and out of hospital to see your cardiologist and your obstetrician more often than other women going through pregnancy. The obstetrician will want to keep a closer eye on your baby than in other pregnancies, particularly having a look at the growth scan. In terms of coming to the later part of the pregnancy and delivery, we know there's an increased risk of premature labour, and an increased chance that if you become less well or we're concerned about your baby's well-being, that we might decide that we need to deliver you early. So there's a lot of reason for why we keep seeing you and we keep having conversations. Increased risk of bleeding postpartum, and just that fact that you need to have in the back of your mind that you might deliver a very small or premature baby, and what that might mean for you and your partner and your family. Every hospital, every state is set up differently. So for example, the hospital where I work at is co-located with a maternity hospital, but that still means that I might end up looking after you in my hospital and your baby might end up being next door. So some of those realities are really important to know about before you suddenly deliver a baby and realise that actually you're not with your baby. And I've put in tiny print down there, not as an ophthalmological check, but really as a population, the chance that you have a baby with congenital heart disease, although that's often the first question that comes from these women and their families, that's a much smaller chance. So in summary, is pregnancy possible? Yes, it's possible, but it's not going to be advisable or possible for every woman with a Fontan circulation. I want to have one slide on men, Fontan and fertility, although that's obviously not the title, because I had a question last year when we were presenting in Brisbane from the mother of a boy still in primary school who wondered about fertility, and we all sort of looked at each other and went, oh, we don't think it's affected, but actually there's absolutely nothing out there in terms of fertility in men with a Fontan circulation. There is a little bit of data about the fact that if you have low oxygen levels and chronic disease, that might affect your fertility as a man as well. And so just so you know that we really do hear the questions we get and think about what we might look into, that Rachel will be running a project out of Sydney. I can't see Rachel. Oh, she's right at the back. And we'll be very interested in trying to explore this further. So if you are a man with a Fontan circulation in the population and you would be keen to participate, and it will probably be either an online questionnaire or a telephone questionnaire, please send Rachel an email, and when that study goes through ethics, then we'll have a group of people that we can contact. So what do we definitely know about pregnancy in a mum with a Fontan circulation? And what's happened over the last couple of years is that a lot of different places have published their outcome data, but there's just this year been a publication that puts all those together. So we have some really consistent data from a bigger group of women, although you'll see when I show you the numbers that they're not enormous. Very consistent data about increased atrial arrhythmias, heart failure, a deterioration in functional capacity and bleeding. But despite the way it's classified by the World Health Organization, there are no maternal deaths in the published series. Now, I can't stand up here and say to you that means that no one has died, because it may just be that those women haven't actually been published and that hasn't been put out into the literature. But to date, in all the published series, although there have been health issues, none of those have reported a maternal death during pregnancy. So what's changed in the year? For those of you in the audience who heard me last year, what's new? So this is a systematic review that I wanted to just bring to people's attention. This was published just a few months ago. That's probably way too small to see. But a large number of records were identified through the medical literature. It ended up just being that 6 studies were felt to fulfil the criteria that had been deemed at the start prior to being included, and I'm really pleased that one of those was the paper that we had from data from the Australia-New Zealand registry, and that's put together the outcomes of pregnancy in 133 women who had 255 pregnancies. And just note there, the first thing, that 115 of those resulted in a live birth, so 45% of those pregnancies led to a baby, but in the rest of those pregnancies, unfortunately, there was a miscarriage or an early loss. In terms of complications in the mother, arrhythmias just over 8%, heart failure just under 4%. But interestingly, obstetric complications were the ones that were actually much more common. So postpartum hemorrhage, 14%, which in this attempt to look at the literature didn't appear to be related to whether they were on blood thinning medication, although there's another study coming up that I think will give us a little bit more information about that. And thromboembolic events just under 2%. For the babies, 59% of them were born premature, 20% of them, so 1 in 5, were small for gestational age, and very sadly 5%, so 1 in 20, had a neonatal death, and I presume that that was related to the fact that they were a very premature baby with other health issues of their own. The really important caveat, however, is that I think everyone around the world has been quite cautious in terms of supporting women with a Fontan circulation through pregnancy, and so we probably need to consider that even though those outcomes are quite sobering, they probably do reflect the outcomes in well women, or more well women, if you like, with a Fontan circulation, as opposed to our less well women, for 2 reasons. One, I think our less well women will have been medically advised against pregnancy, but secondly, I think if you are less well, you are less likely to get to the point of conceiving in the first place, and secondly, possibly less likely to get to the point of actually realising you're pregnant, even if you have conceived. So I've just mentioned anticoagulation in pregnancy because I think this is something about which we still don't have great data. What should we do? What's better? And certainly the guidelines at the moment suggest that if you've got a pre-pregnancy indication to be on anticoagulation, that should continue in pregnancy. Really important to recognise that pregnancy is a time when women are more likely to clot anyway. And that's for women without heart disease, and the postpartum period in particular, so the first 6 to 12 weeks post-delivery are actually the highest risk time in terms of getting a deep venous thrombosis or a pulmonary emboli. So this is a study that's been managed out of the US and has tried to get really into much greater detail about the management, anticoagulation or antiplatelet-wise, during pregnancy. They've recruited 74 women with 97 pregnancies, had very similar data in terms of premature deliveries and small birth weights. But the really interesting data that's come out is 35%, so 1 in 3 had a bleeding complication. Most were a postpartum hemorrhage. They're still doing the statistics, and I know that because I got a data query 48 hours ago for one of them, so I haven't got the final outcome for this. But I do know that from the very initial look at the data, they don't seem to think that there's a relationship between what medications mum was on and the bleeding, and that will be presented in October at the AHA and subsequently published, and we'll know more. This is something that I think I did mention last year, and unfortunately is yet to start, but we are very, very close. So one of the interests that I have is whether having had a pregnancy might adversely affect women's health many years post-pregnancy. And so what we're really keen to do, and this is something that we'll need to really collaborate around the world, I think, in terms of getting numbers, is to look at women with a Fontan circulation, match them to other women with a Fontan circulation where they differ according to whether or not they've had pregnancies, but match them for the type of Fontan and the type of systemic ventricle they have and the age they were when they had their Fontan circulation, and then just see what happens down the track. Do we really think that pregnancy might have an adverse effect? Can we prove that? So that we're just waiting for the final sign-off between the legal agreement between us and the centre and the states, which is sort of managing the project as a whole, and then we'll be able to start putting data together. So hopefully I'll have something to tell you about that in the next couple of years. So in conclusion, pre-pregnancy counselling is essential, but it needs to be individualised, which is why if you're still sitting there going, but I still don't know about me, I apologise, I can't answer that for you, but please have a chat to your cardiologist. I think the risks of pregnancy are consistently described, but that doesn't mean that we know everything. I think there are some obvious questions at the moment which I've already raised, so anticoagulation, the long-term outcome. One of the really simple things that I think we don't know about is how do we best actually risk stratify pre-pregnancy, and I think that's something that we need to turn our thoughts to. You know, are we getting it right? Could we do that better? And a question that's come up but might still be some years away in terms of us understanding it is whether there might be a different risk profile for women with a hypoplastic left heart. So yes, pregnancy is possible for many women with a Fontan circulation, but it does at minimum carry an increased risk, and that's both to mum and to baby. And so I do really want to thank you, because if you're a woman with a Fontan circulation in the audience and you've had a baby and you're part of the registry, then your data has been referred to in terms of the findings that I've been able to share with everyone today. And I am really conscious that although this is my job and my passion, because I love it, it is your life. And so thank you very much for letting us have that insight into what having a baby has meant for you, and hopefully being able to use that information to better explain what the future might hold for other people. Thank you.